All right, everyone. So we'll go ahead and get started on chapter 17. This is over respiratory emergencies. There'll probably be two, maybe three parts to this chapter. It depends on how long it takes me to get through this first part. So I know I say this a lot, but I can't stress it enough for this single chapter. This is probably the most high yield chapter that we'll cover. Why is that? Because EMTs and paramedics, but really especially EMTs, they save lives by addressing respiratory emergencies. They really do. The difference you make in the pre-hospital environment, almost all as an EMT, will almost always relate to some type of respiratory emergency. Like you're intervening in some type of respiratory emergency, and that's where you really make a difference. The biggest difference, I should say. So with that, examiners go after this because it's so high yield. So you will have to watch this video and read the chapter multiple times because literally everything I say over the next 2 to 3 hours is going to be tested. You will be tested on pertussis. You will be tested on COPD, asthma, upper airway, lower airway, anatomy, physiology, pathophysiology, epidemiology, right? You're going to get tested on that. This is an examiner favorite on the National Registry. It's a huge, 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 huge chunk of your exam that they'll go after. So just realize very, very important information that I'm about to tell you, and it's heavily tested. Okay, so we'll just review some real quick medical terminology. So what does the word dyspnea mean? Okay, dyspnea. The P's somewhat silent, but dyspnea. Um, it means shortness of breath or difficulty breathing. Okay, so you'll hear this a lot, right? So the patient's complaining of dyspnea. So don't be deer in the headlights when you hear that. It means shortness of breath, and examiners will use this on exams. And if you don't know what this word means, you're going to be lost. Okay, so it's a very common complaint for someone to say they can't breathe or that they're short of breath. And so this is where we have to be clinicians and we have to use history and assessment and intuition and our training and knowledge to come up with a diagnosis and work from that diagnosis. And so you have to realize that shortness of breath is not always a respiratory emergency, right? So it's not always asthma, COPD, epiglottitis, right? Something weird like that. It's very commonly anxiety. Like you see this a lot, and examiners will do this, right? They'll give you a very anxious 18-year-old female and tell you that they have chest pain and shortness of breath, and you're not supposed to give aspirin and nitro because it is anxiety induced, right? And so they'll trick you sometimes on that to where you need to ask yourself, is this anxiety? Is this truly based on my assessment and lung sounds, is this truly a respiratory emergency? That's kind of where this comes into play. So realize that uh, respiratory, and this is why it's so high yield, it touches every single body system, right? Endocrinology, neurology, cardiovascular system, respiratory system, GI system, even skeletal muscular, the skin, everything, immunology, everything will touch the respiratory system. And we see this in virtually every disorder, right? There will be some type of respiratory change that takes place. So realize it shows up a lot. So just a real quick anatomy and physiology review. This is tested because it's worth knowing these. Okay, so the upper airway. So here's how they'll do this, right? They'll say, is the oral pharynx part of the upper airway or lower airway? It's the upper airway. So the division of the upper airway and the lower airway, not my opinion, is the vocal cords, also known as the larynx. So that's right here. Let me choose a different color. That's right here at the larynx, the vocal cords, okay? That's the division. So larynx, the oropharynx, the nasopharynx, the nose, the nares, the mouth, the tongue, right? All of that is upper airway, okay? So don't get duped and let them, ask you, the patient has a foreign body airway obstruction in the oropharynx. Is this an upper airway or lower airway obstruction? It's an upper airway obstruction, okay? And that's how they'll test that. And then so we know that at the vocal cords, also known as the larynx, below that, we go into the trachea. And then at the division of the trachea is called the carina. Also, my dog's name is Karina. And then it branches off to the left and right lungs, okay? And then it goes into the bronchioles and the bronchi, and then it goes into the alveoli. And we know these alveoli are these grape-like clusters where actual gas exchange takes place. We're going to talk about that on the next slide. But we need to know the gas exchange takes place in the lower airways at the lowest level at the alveoli, the grape-like clusters. And this is where the body will drop off carbon dioxide, the byproduct of cellular respiration, and it picks up oxygen through what process? The process is simple diffusion, where we go from an area of high concentration to low concentration. They trade off at the capillary membranes that are surrounding the alveoli, and then blood goes back around to the cells to perfuse. So that's kind of a general idea. So let's recapitulate with this image as well because this is very important. So we go down from the bronchi to the bronchioles. And I want to point out that there is smooth muscle right here, okay? So when we start talking about asthma, okay, where these smooth muscles clamp down because of an allergen, that it is affecting some of the smallest airways, not the very smallest, but some of the smallest airways, okay? So realize bronchioles do have smooth muscle, okay? And then so we have these arteries and veins that come down, and then we see these grape-like clusters known as the alveoli, right? And so what's happening is deoxygenated blood, so venous blood, or really it's kind of not, I shouldn't say that. Deoxygenated blood is coming down through the pulmonary artery. And I want to point something out, and I've told you this before. Remember, the pulmonary artery, it is carrying blood away from the right ventricle, away from the heart. Remember, artery with an A and away with an A, right? It's carrying away from the heart. But in this exception, in this case, it is deoxygenated blood. So let's point something out. You'll probably notice that most of the time arteries in books are painted red, right? In this case, it is not a mistake. It is not an erratum. It is painted blue because it is deoxygenated blood. So it's carrying deoxygenated blood from the right ventricle through the pulmonary artery away from the heart down into the lungs. It is deoxygenated and it is going down into the alveoli. What is inside this blue blood? Carbon dioxide. What is low inside this blood? Oxygen, okay? So what happens is it's carrying this carbon dioxide, CO2, okay, down to the alveoli. And what you did was you breathed in oxygen. Remember, ambient oxygen in the air is around 21% oxygen. The rest of it's pretty much nitrogen. But so we have oxygen down here within the alveoli, right? It's a gas. And then we have CO2 dissolved in the plasma of this, in this case, arterial blood. And so what happens is simple diffusion takes place, right? We have a high area of concentration in the pulmonary artery blood of CO2, and we have a low concentration of oxygen, but we have a higher of a concentration within the alveoli, so this exchange takes place. High concentration to low concentration. This is like the guy that's spraying Axe body spray, and it's going from an area of high concentration to low concentration. This is like the guy ripping farts in class, and it makes its way to your nose. High concentration, low concentration. So this gas exchange takes place, okay? And then it'll pick up this oxygenated blood through the pulmonic vein. Okay, now we go through the pulmonic vein, which, yes, veins are typically deoxygenated blood, but this is the exception, and they will test you on this because it is an exception to the rule, and examiners love exceptions to the rules. So what happens is it carries deoxygenated, or it carries oxygenated blood through the pulmonic vein, and yes, it is painted red. That is not a mistake. It is red because it is bound to, the hemoglobin is bound with oxygen. So you've probably seen this before, but if you've ever had your blood drawn, it's typically a venous sample, and you'll notice it's a dark purple. That's not by chance. It's because venous blood typically is desaturated of oxygen. And what happens is when arterial blood typically is exposed to oxygen, the hemoglobin itself will bind to oxygen and it becomes a red color. And you've seen this, right? So if you've pricked your finger, it might come out a little blue. If you let it sit or rub it on some paper, what color does it turn? It turns red because it's exposed to oxygen in the environment, okay? So those are some general principles. You do need to know how this works. Know the process is done through simple diffusion. Very high yield information right there, okay? And I just explained this, so I won't hit it again. Actually, I will, because it's that important, and students get this confused all the time. So let's do a real quick recapitulation of blood flowing through the heart, okay? So we have cells down here, right? Somewhere, let's just say this is in your calf, your gastrocnemius, if we want to get fancy, okay? And so what happens is your calf does its little work, all right? You're at the gym doing your little calf rises. Who doesn't want bigger calves? I know I do. So you're doing your little calf rises, okay? You're using up ATP. And we know in order to generate ATP, we need oxygen and glucose. So cellular respiration can occur so we can regenerate more ATP, okay? But the byproduct of cellular respiration, especially in the electron transport chain, is CO2. And so what happens is CO2 is produced, okay? We got that part. It goes up through eventually then for your vena cava. That is a big friggin' water hose running up through the right side of your diaphragm or of your chest, okay? And it kind of loops around and it'll come into the right atria. And in the right atria, it goes through the right atria, through the, remember we try before we buy, so the tricuspid valve, into the right ventricle. From the right ventricle, it goes into the pulmonic artery, okay? Through the pulmonic artery, it goes down through the lungs, Diffusion takes place. We drop off CO2, we pick up oxygen, and now it's red. It's oxygenated blood. But it's going through the pulmonic vein, because remember, veins go back to the heart. And so the pulmonic vein is carrying this oxygenated blood, which that's just weird. Veins carrying oxygenated blood. Yes, this is the one time it happens. And then it carries it into the left atrium, down into the bicuspid mitral valve, and then out through the aorta. Okay, this is the aorta, and then boom, it drops off this oxygenated blood back to my gastrocnemius or my brain or my kidneys or wherever it needs to go. It drops off the oxygen, picks up some CO2, and this happens until we die, hopefully. So that is the normal process of gas exchange and really perfusion in a nutshell. So here's my challenge to you. You need to be able to explain this to a sixth grader, okay? So you need to do what I just did for you, right? You need to be able to explain this. It's that important. So I'm not bullshitting you. You got to know how to talk your way through that to someone, because if you can explain it to someone, then you know it well enough to be tested on it, okay? So do know how to explain that to a sixth grader or a seventh grader or something like that, someone who doesn't know medicine, okay? Now, what they're pointing out here on this side of the slide is an important concept that children have really big tongues, okay? They have big tongues in relation to their mouth, right? So what this becomes a problem for upper airway obstruction, okay? They have big floppy tongues. And you can see this demonstrated here, right? Let's just zoom in. You can see that this passage right here is a lot smaller than the passage in an adult's airway, okay? Also, I'll point out a kid's trachea is also smaller than an adult's trachea. Also, I'll point out a kid's trachea is softer than an adult's trachea. You can feel your trachea up here, it's rigid. Okay, there's cartilaginous rings that go around your trachea that makes it a solid pipe. But kids, that cartilage is still pretty soft, so you can really choke a child, like a kid can cut off their trachea very easily. And in fact, I'll demonstrate this for you, right? If you were to really hyperextend a kid's neck, their trachea can kink, okay? And so you really can't do that to an adult very easily. So just be aware that kids, 3 real important differences in a kid's airway, okay? First off, they have really big tongues, so this includes their oropharynx, okay? And the tongue can fall back, and it's really big and floppy, okay? So they have big tongues. The second one is they have a smaller size trachea. The third one is they have a softer size trachea, okay? Or a softer filling trachea, okay? So real quick, air goes in through the nasal cavity. There's these things called turbinates, right? Like a turbine, and it swirls around the air. And so it moistens it and it heats the air, okay? There's a lot of blood up in your nasopharynx, this being your nasopharynx, that is designed to heat and humidify your air. It's also supposed to filter, okay? So your little nasty nose hairs and stuff, that's designed to filter air, okay? And to kind of pull out particles of it. Okay, same thing with your boogies and your snots and all that, right? It's kind of designed to humidify and filter air, okay? The idea is to filter the dust particles prior to getting down to your alveoli. So it passes through, this is the palate, right? And there would be your like uvula, but right, really probably about here is the vocal cords, and then it'll go down through the trachea. What's this division called? My dog's name, Carina, right? Carina. And then it'll go into the left and right bronchus down into lungs, okay? So moving forward. Now, the book gets a little pedantic on me sometimes, and it annoys me, but we'll cover it. So there's 2 processes that occur in this thing called respiration, right? And it's inspiration and expiration. So it makes sense if you're inspired, right? Right, you're breathing in. And if you're expiration, it's breathing out. Like, I feel like that's intuitive. I don't have a lot to add on that. But this is where it gets weird. The actual process of moving air in and out of the lungs is called ventilation, okay? So you're ventilating right now, right? Air in and out. And if you stop breathing, right, I will use a BVM and I will ventilate for you, okay? So I can ventilate for you. I really can't respirate for you. So that's kind of the thing to realize. Like, humans independently respirate, but if you stop ventilating, I have a ventilator right here in my hand and I will ventilate you, okay? So that's kind of the difference between the 2, okay? So we covered all the rest of that. I'm not saying it again. Now, this is just again, I keep saying the same thing, but notice it keeps showing up because it's important. So let's just act like this is my calf, right? The gastrocnemius, right? Down on my leg. What happens is this is bringing air. This is at the capillary level, okay? Remember, we go, veins, venules, capillaries. Then it goes capillaries, arterioles, arteries, okay? So, and bigger to smaller, smaller to bigger. And so what happens is these are red blood cells, and they actually do look like this, right? They have this biconcave disc shape to where they're bound with oxygen when they're red. And so what happens is it's like, oh, hey, little gastrocnemius cell, you don't have a lot of oxygen, so I'm going to drop off my oxygen to you. Oh, cool, you happen to have a lot of CO2. I will pick that up on my way out. And so diffusion takes place, and it drops it off, and then it goes out. So this is an ongoing process, and it gets a little pedantic, but I do want to say oxygen is bound to hemoglobin. Okay, that's red blood cells, right? Red blood cells contain hemoglobin, right? Red blood cells themselves are not hemoglobin, but they're mostly made up of hemoglobin. Okay, so red blood cells do contain hemoglobin. And so oxygen is bound to hemoglobin. Okay, and it turns red when it's bound, right? And so each hemoglobin can hold 4 molecules of oxygen. And where it gets really weird, and I hate to tell you this, but just stick with me on this, is CO2 actually doesn't bind to hemoglobin. It's weird. It actually binds to the plasma within the blood. And so that's a little bit extra, but I just want you to know that yes, CO2 is carried in the blood, but it's mostly carried in the plasma of the blood. It's not really bound to hemoglobin. And that's a little pedantic. I'm just telling you this in case this shows up, but it's this weird thing with carbonic anhydrase and the shift that happens. But I don't think we need to know exactly how that happens. Just know hemoglobin or red blood cells contain hemoglobin, which carries oxygen, and then CO2 actually is carried in the plasma of the blood, but you just need to know that CO2 is carried in the blood, really. Okay? Now, what stimulates us to breathe, in the words of the water boy, is the medulla oblongata, right? So the medulla, okay? Where's the medulla? It's in the brainstem. And so if I were to draw the brainstem right here, right? Here's your big brain, right? So you'll have the pons, the medulla, and then it goes down your spinal cord. So this is the pons, the medulla, and this is the midbrain, okay? And here's the brain. So right here, at the pretty much at the bottom of the brainstem, right before you get to the spinal cord, is the medulla. And so the medulla is constantly sampling blood. And so it's saying, okay, there's a lot of CO2 in the blood, so I need to breathe faster. And an important concept that we're going to cover here in a bit, but I'm going to lay the foundation now, is that CO2, carbon dioxide, is what stimulates us to breathe. It's not oxygen. I know, I'll say that again. CO2, carbon dioxide, is what stimulates us to breathe in the medulla. Where is the medulla located? It's in the brainstem. So the brainstem's sampling blood, and it's like, oh, there's a lot of CO2 in the blood. Let's breathe faster. And that's what stimulates us to breathe. And if you want to test my theory, go run to the stop sign and back, right? And so what you're going to see is you're going to have a buildup of CO2, and you're going to be huffing and puffing by the time you get back. The medulla is picking up that CO2 and saying, oh God, we got to breathe faster. And so the normal process of inspiration and ventilation, right? What stimulates that, what drives us to breathe as normal humans, those of us sitting in this classroom watching this video, is usually, almost always, it's going to be carbon dioxide, not low oxygen. There isn't a case where it is low oxygen. We're going to talk about that in a bit, but not right now. I need you to know what stimulates us to breathe is a buildup of carbon dioxide in the blood. Where is driving that process? The medulla. So here's why this is important. The brainstem, the medulla, right? It is so important to life that when we have herniation or something pressing or something that is injured, the medulla, we can quit breathing because the medulla itself is what's telling us to breathe, okay? So how does this happen? I'll just show you on me. The diaphragm and the intercostal muscles contract, okay? So we have this muscle that I've talked about a lot called the diaphragm. It normally sits like this up in my chest, right up underneath my ribs, okay? And so when I have a buildup of CO2, it says, okay, I need you to contract. And what happens to muscles when they contract? They get tight, just like my bicep, right? When it contracts, it gets tight. Well, the same thing happens to the diaphragm. It gets tight, so it's going to go ahead and shrink in size. When it goes like this to this, it's pulling. It's pulling air down, causing a negative pressure, bringing air through my nose, through my mouth, down through my trachea, into the bronchi, into the bronchioles, into the alveoli, right? So that's how that's happening, okay? The thorax enlarges, so the interpulmonary pressure falls below the atmospheric pressure because I'm sucking air in, so it's a negative pressure. I'm pulling air in, so it has to be a negative pressure. And then the air fills the lungs, the tissue or diffusion takes place, okay? And so when the pressure outside the thorax equals the pressure inside the thorax, inhalation stops. So that's a weird sentence. So let's break that down. When pressure outside the thorax equals the pressure inside the thorax, inhalation stops. So remember, I'm saying I'm causing a negative pressure by breathing in, but I can't create such a negative pressure that I'm going to beat. There's a point where the negative pressure becomes equal with atmospheric pressure, right? So like the amount of air in my lungs is the pressure wise is probably now pretty equal to the air outside of my lungs. And so inhalation stops, okay? You don't want to overexpand your lungs. There's these things called baroreceptors, B-A-R-O receptors, baroreceptors, that say don't breathe in too much, okay? That baro means like pressure stretch. So don't stretch your lungs too much, right? Don't blow a lung because you can do that. We're going to talk about what that is, okay? Now, inspiration is an active process. It takes ATP, it takes brain function, it takes thought, right? It takes your brain, it takes muscles. It's an active process, okay? Now, test question. Expiration is a passive process, okay? So someone dead can breathe out. I've told you all this before. So the chest expands, right? Stretch receptors send a signal to the apneustic center to inhibit the inspiratory center. And expiration occurs, okay? And again, this is to prevent overexpansion of the lungs. And so an interesting theory, and it's not even a theory, right? But the interesting thing is that expiration lasts twice as long as inspiration. What? So it takes us twice as long to breathe out than it does to breathe in. And if I didn't tell you, like, think about it, right? It's intuitive, right? So 1, 2, right? So it's almost like this 1-2 dogma of like, it takes about a second to breathe in and about 2 seconds to breathe out. Okay, so you'll see that. And this ratio becomes important when we talk about obstructive versus restrictive pulmonary pathology, okay? So it takes about 1 second to breathe in, and it takes about 2 seconds to breathe out, okay? So you got to know that. Now, so yeah, I keep hitting this. Adequate ventilation, perfusion must occur for the body to receive the nutrients and oxygen. What's it called when cells don't get the right amount of oxygen delivered to them? We have a special word for that. Shock, right? It's shock, okay? So when cells are not perfused, it's shock. And there's different types of shock. So there's different like things that can interfere with this whole oxygen CO2 McJigger that we've been talking about. So it could be an upper airway obstruction, like a freaking battery or deviled egg stuck in your throat, okay? It could be a lower airway obstruction, like cigarettes causing COPD and asthma, okay? It could be chest wall impairment, like a baseball bat or a gunshot to the chest, okay? Or it could be neurological control problems, right? It could be my brainstem is herniating from a brain bleed, okay? So there's these different ways that we can end up with, respiratory insufficiency, right? Lack of perfusion, lack of ventilation. And so we're going to talk about what each of these are and dig deeper into them, okay? Now, this is a little bit extra. It was in your book, so I need to cover it. But you should know, I guess, the alveoli are made up of 2 cells, okay? We have these things called type 1 pneumocytes. And basically, I'll just zoom in. These are the really thin ones where actual gas exchange takes place. And then we have the stem cells of the lungs called the type 2 pneumocytes, right? And so these are the ones that produce like mucus, not mucus, but like surfactant and stuff like that. And then we have alveolar macrophages, and those are the little Pac-Man guys that go and chew up all your nasty dust and stuff that ends up in your lungs and viruses and stuff like that, or really bacteria. But this is something they want you to know. So I'll say it again. Type 1 pneumocytes, this is where gas exchange takes place. They're by far the most abundant. Probably 98% of your lung is type 1 pneumocyte, or your alveoli. And then type 2 pneumocyte, very small percentage. It makes so they're stem cells, right? So they make new cells. They make the new type 1 alveoli, but they also produce surfactant. What is surfactant? Surfactant is this thing. It's like you can almost think of it as like boogers or snot. It's this stuff, like it's oil. It's not oily, but like what it does is it keeps the alveoli open, okay? So you're essentially creating this like surface tension area of the alveoli that tells it to stay open. It's almost like this slime that's sitting within your bicycle tire that's telling it stay open. And without surfactant, our lungs tend to collapse. Our alveoli tend to collapse on themselves. And the collapse of alveoli is this very weird word called atelectasis. And the reason I'm telling you about surfactant is because this becomes important for newborns. Newborns, they're type 2 alveolar cells. They don't develop until late in utero, like after week 28. Remember, full-term pregnancy is 40 weeks. So they don't develop until late in utero. So if we have a premature baby, they don't have enough surfactant. So, oh crap, if they don't have enough surfactant, their alveoli and their lungs are not mature. So they end up collapsing on themselves, and they end up with this highly membrane disease and newborn respiratory distress and all these issues that occur that we'll talk about later. But surfactant, it reduces the surface tension so like it doesn't collapse on itself. So I want you to think surfactant is what keeps the alveoli open. And when we don't have enough surfactant, the lungs will tend to, not the lungs, but the alveoli will tend to collapse on themselves. Okay? It's kind of weird, but it's worth knowing. Okay. So yeah, conditions relating to ventilation and or perfusion can prevent oxygen from reaching the bloodstream. So we'll talk about this. I'll just lay this now. So ventilation is it's abbreviated with a V, and perfusion's abbreviated with a Q. Okay, so sometimes we'll talk about this thing called a VQ mismatch and blah 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 blah. We'll talk about this, but just I'll lay the foundation out. V, how convenient. V for ventilation. But perfusion, for whatever reason, they decided not to use the word letter P. They use the word letter Q. Q equals perfusion. Okay, it's weird. So this is something to worth knowing. We all know someone that has been killing cigarettes for their whole life, and they have COPD. You know someone who has been smoking for probably 2 decades or more. They have COPD. Okay. Well, what happens is when your lungs get all jacked up from cigarette smoke. Don't smoke, people. What happens is you can end up with this thing. Your body will get tricked, and it'll say, "Well, geez, body, you're not perfusing the cells really well, so let's just produce more red blood cells. That might fix the problem." And so we end up producing so many red blood cells in response to this hypoxemia, that your brain will or your kidneys will end up producing more red blood cells. And this has a really weird name, but it's a name that we got to know, called polycythemia. Okay, so polycythemia means too many red blood cells. This almost always, that you need to know, almost always happens from chronic hypoxia. And so it produces some problems when you have too many red blood cells. You can end up with hypercoagulability, right? So if you have too many red blood cells, they can coagulate. Okay, so that can create problems. You end up with like red flush skin, digital clubbing, which is like when your fingers get real fat, the tips of your fingers. There's a few different, red skin, itchiness. There's a few ways this will create problems for people, but they want you to know, and I think you should know. If you have chronic lung disease, one of the responses of your body, there's many, one of the responses of your body is to say, well, shit, let's just create more red blood cells. Because we know red blood cells carry oxygen, so maybe if we just saturate the blood with red blood cells, we'll get more oxygen down to our calf and up to our brain and down to our kidneys, right? And so that's kind of the idea of polycythemia, okay? Now, this is a very complicated subject, cor pulmonale, but I'm going to cover it because it's tested in the word cor pulmonale, right? Very scary, right? It sounds intimidating, but it's really not a hard word, okay? So cor pulmonale, this could also be called cor pulmonale. I've heard it called that. It's right-sided heart failure because of chronic lung disease, okay? Yeah, and if you could really literally just walk away, oh, cor pulmonale, that's when the right side of the heart fails because the lungs are jacked up. You're in good shape. But let me explain to you how this happens, okay? So we'll just draw some lungs right here, right? This is the right side, this is the left, okay? And within the lungs sits your heart, okay? And so not drawn to scale. So what happens is when, this is complicated, so stick with me, but this is important. When the alveoli, when the alveoli don't get enough oxygen, they do this thing called shunting. And so just imagine this with me. You don't get enough oxygen, okay? And let's just say it's like a COPD, so this is chronic. So they don't get enough oxygen. Another way the body will respond is the little vessels within the lungs will clamp down. And kind of the idea of this is, let's just say like I had pneumonia right here, okay? If there's like a big pile of pus down here in my right lower lobe, there's no reason for the body to shift a bunch of blood down there to oxygen or to try to ventilate and perfuse. So what happens is the lungs will say, yo, I'm shut off, I'm not working. So what it'll do is it'll clamp down. And so it clamps down these vessels and it'll shunt the blood. Instead of going here, it'll go here and here and here, right? So it shunts blood. Okay, and this happens in all sorts of pathology, right? Pulmonary edema, pneumonia, atelectasis, COPD, asthma, blah 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 blah, heart failure. Okay, it happens. So what you think about this? When you clamp down vessels, what happens to the backflow? It increases. So really think about this, right? If I'm going to squeeze down on a water hose, what's going to happen on the front end of the water hose, right? Or the back end of the water hose, right? It's going to build up pressure. And so the right side of the heart is not in a very, it doesn't have to pump very hard. Because think about it. The right side of the heart, all it has to do is pump from here to here, here to here. It's not going very far. Compared to the left side of the heart, it has to pump up to my head and down to my big toe. So the right side of the heart is very thin. It doesn't have a lot of muscle normally. But what happens is when someone has chronic lung disease and their vessels in their lungs are clamping down because of shunting, right? What happens is you end up with an increased pressure on the right side of the heart. And so the right side of the heart through the pulmonary artery, it starts backing up. And so when you start backing up blood into the right side of the heart says, oh my God, there's so much blood in this right side of the heart because it can't go to the lungs because it's being pushed down on, it's being squeezed. So it starts pumping harder and harder and harder. And so just like if I were to go to the gym and start pumping it harder and harder and harder, right? My muscle's going to get bigger. Well, the right side of the heart will get bigger. And so when the right side of the heart gets bigger, it eventually fails. And this failure of the right side of the heart, because of chronic lung disease, has a fancy name called cor pulmonale or cor pulmonale. Okay, pick one, I don't care. But that is the idea of cor pulmonale. And I don't think that books or educators tend to explain this to students because it's really not too complicated if I can explain it to you. But that's called cor pulmonale or cor pulmonale. If you just know the line, cor pulmonale is right-sided heart failure because of chronic lung disease, and it's really because the lungs are clamping down because of hypoxia. Not the lungs, but the vasculature in the lungs are clamping down. Then you got it. That's really what you need to know. Okay. Now, carbon dioxide retention and hypoxic drive. Ooh, this is the stuff that nightmares are made of for EMT students. Okay. So we talked about this. When my calf does its little job, it rises, it increases the amount of, if I'm going exercising or running to the stop sign and back, it increases the amount of carbon dioxide in my blood. What is carbon dioxide? It's the byproduct of cellular respiration, and it's a byproduct from the electron transport chain. So we end up with carbon dioxide in the blood. Well, when your lungs are jacked up, in the case of COPD, right, chronic obstructive pulmonary disease. So again, someone who's been smoking for 2 decades. What happens is you have so much carbon dioxide in your blood, and it's always in there. You end up retaining carbon dioxide, that your little medulla gets confused, and it's like, bruh, I'm doing everything I can to get rid of this carbon dioxide. I give up. I can't do it anymore, right? So what happens is, instead of, right, like me and you, right, my medulla telling me, hey, there's a lot of carbon dioxide, you should breathe. When there's always, and this happens over years, when there's always too much CO2 in your blood, what'll happen is it'll shift away from the medulla and it goes into your periphery, okay? And so what happens is your periphery will say, instead of saying, hey, there's too much CO2, what happens is your periphery will say, oh, there's actually not enough oxygen. And what is it called when our cells don't get enough oxygen? Hypoxia. What's it called when our cells or when our blood doesn't have enough oxygen in it? Hypoxemia. Hypoxemia means there's not enough oxygen in your blood. Hypoxic or hypoxia means your cells are not getting enough oxygen. There's a difference. So what happens is we have this backup system that's saying, oh man, there's always too much CO2, so let's divert to the backup system. Let's go to plan B. And so it'll switch to your periphery and say, there's not enough oxygen, so we need to breathe more. So this phenomenon that happens in people with chronic lung disease, again, this doesn't happen overnight. This is years, chronic lung disease. What happens is we get this thing called hypoxic drive. So who gets hypoxic drive? Those with chronic lung disease over years, this will happen. And so instead of CO2 telling us to breathe in the medulla, what tells us to breathe is low oxygen in our periphery. Okay, that's how, and break down the word hypoxic drive. Hypoxic, cells aren't getting enough oxygen, are driving us to breathe. Hypoxic drive, okay? So again, the examiners love this because it goes against the rules, right? The normal rule is that CO2 tells us to breathe. And now that low oxygen is telling us to, or high CO2 normally tells us to breathe. But now that low oxygen is telling us to breathe in a hypoxic drive from chronic lung disease, examiners love asking students about this, okay? Now, why does this become important? You're like, okay, cool, Hunter. Like, why do I need to know that? I'll tell you why. Because if I were to put a non-rebreather on me, okay, let's say I have a hypoxic drive, right? I've been killing cigarettes for like 20 years, okay, smoking 2 packs a day. And so what happens is I have hypoxic drive. There is this debunked theory, but I'm going to explain it to you, of if I put a non-rebreather on me, right, with 100% oxygen, what's the normal oxygen in the atmosphere? 21%. If I put a non-rebreather, 99, 100% oxygen on me, you could eventually have so much oxygen floating around in the blood, you could eventually convince the body to not breathe as well. With this said, when I went to EMT school, they were acting like this stuff could happen in 10 minutes. It does not happen that way. I promise. That will get you questions wrong. When it does happen is over hours, usually really days. This becomes a problem when we're like ventilating patients, like with an endotracheal tube, right? With 100% oxygen, just oxygen in their face. That, and we do it for hours, right? That can switch off someone's hypoxic drive, and now they are going to have a high level of CO2 and a high level of oxygen, so their brain or their body will get tricked and say, well, just don't breathe. This doesn't happen, this will not happen in the back of your ambulance, okay? So the general rule is we still give oxygen to patients who have SATs less than 94%, okay? Again, it used to be stressed that this would happen in the back of an ambulance. It doesn't. It's a misnomer. It's a myth. It's a lie. They taught us wrong. This happens over hours. And unless you're working in Terralingua, Texas, you're not going to be with a patient in the back of an ambulance for hours, okay? So this is just something to know, and this is how this shows up on exams, okay? Now, hypoventilation. Hypo means below ventilation, so low ventilation, right? So excess carbon dioxide can build up if we don't breathe it off and ventilate well. So excess carbon dioxide, and it results in this thing called respiratory acidosis. And we've talked about this, right? So what is respiratory acidosis, right? So acidosis means a high amount of acid in the blood. What's the normal pH of the blood? Help me. 7.35, excuse me, to 7.45, excuse me. So which way is acidosis, right? If someone's acidotic, respiratory or metabolic, it's going to go down this way to this way. So this is acidosis, okay? And if that means if we go this way, it has to be alkalosis or it's basic, okay? Excuse my terrible handwriting today. So what happens is we know that carbon dioxide is acidic. I've said this like a billion times. So carbon dioxide is acidic. So as it builds up in the blood, as the carbon dioxide builds up in the blood, the pH drops. Remember, pH is inversely logarithmic, right? So the pH will drop down to, let's just say, 7.25, right? And why is it 7.25? It's because we have this acidic stuff floating around in the blood known as carbon dioxide, okay? And so here's how this works. If we hypoventilate, we know when we ventilate, we're breathing out CO2. So instead of breathing 16 times a minute, we're breathing 4 times a minute because we overdosed on fentanyl, right? Your CO2 will build up in your blood. So your pH will go from 7.35 down to maybe 7.25, 7.2. And that's called respiratory acidosis. Well, fear not. There's a very quick cure to this, okay? It's a BVM. If someone does not ventilate adequately, the answer on the National Registry, the answer on your exam is to use a bag valve mask and to ventilate for them, right? 12 times a minute, 16 times a minute, 20 times a minute, I don't care, right? Ventilate for the patient, okay? Because when I ventilate for them, I'm forcing air down, and through the passive process, air, CO2 is going to come up, right? So this is how we fix hypoventilation. It's such an easy fix, and it is a rapid fix. I can very rapidly correct someone's respiratory acidosis with this bad boy right here. It saved more lives than Jesus himself. You can save a lot of people with this if you know how to use it. Now, with that said, this is difficult to use. We'll talk about that in the lab. But now, what causes hypoventilation? Impaired lung function. Your lungs are jacked up. Okay, COPD, chronic obstructive pulmonary disease, okay? What else can jack it up? Impaired mechanisms of breathing. We see this a lot. If I were to take a baseball bat to your chest or a steering wheel to the chest and you break a bunch of ribs, it hurts to breathe. So we don't have these really good mechanics of breathing when it hurts to breathe, okay? The impaired neuromuscular apparatus, okay? Fun fact, fentanyl shuts down your brain. It can shut it down so much it can shut down your medulla or suppress it to where your brain's like, so chill. It won't breathe as well, okay? and reduced respiratory drive. Again, this can happen through fentanyl, or heroin, or benzodiazepines like Xanax, or barbiturates like phenobarbital, right? There's a lot of drugs, heroin, stuff like that, oxycodone, Norco, Vicodin, all those guys, morphine. So the list goes on. But basically, drugs can cause this. Also, like a gnarly stroke can impair the neuromuscular apparatus. Okay, trauma to the neck can impair the neuromuscular apparatus, stuff like that. Okay. Now, hyperventilation. This is when your arterial carbon dioxide will fall below the normal level, okay? And there's really not very many times this happens physiologically, or I'm sorry, pathologically. It does happen physiologically, or it's still kind of a pathology in anxiety, right? So we've all seen someone that's like panicking, right? Doing the whole I just failed my exam stuff, and basically they're breathing off too much CO2. Okay, so the pH will go up to from 7.35 to 7.45, the normal, up to like, I don't know, 7.55. Okay, they're breathing off too much CO2, so we're getting rid of too much acid. So we become alkalotic or basic, so the pH increases because we're losing acid because we're breathing it off. We're breathing off our CO2. So this presents with tachypnea, all right? Fancy word, tachypnea, right? Tachy, fast, pnea, right? Breathing, fast breathing. Without a physiological demand, will cause respiratory alkalosis, okay? So a 7 pH greater, or a pH greater than 7.45. And so alkalosis, it can cause a hyperventilation syndrome, right? And so alkalosis causes symptoms of hyperventilation syndrome, yeah. And so there's this, I think we don't really cover it, but you'll see this a lot clinically. So basically, classic vignette, right? I'm going to give you a test question on this, right? 21-year-old college senior fails their final exam. You get called for shortness of breath and chest pain. You get there, patient's breathing 40 times a minute, is hysterical, crying, upset, says that they're dizzy, their hands are cramping, they have chest pain, and they feel like they're going to pass out. Why are their hands cramping? When you breathe off too much CO2, you can get this thing called, you want to sound sophisticated, you've diagnosed this, but we see this a lot. Carpopedal spasms. Carpo, right? Hands, pedal, your feet, spasm, okay? So what happens is we breathe off too much CO2, our blood becomes alkalotic. Proteins, albumin, that is normally bound, calcium that is normally like within this, this gets complicated. I'm just going to say, if you breathe too, I'm not going to explain how this happens. If you breathe too fast, basically, your muscles will spasm. The reason is calcium becomes bound to protein. That's what happens. And it's because of the alkalotic environment. But we see this a lot. So how do you fix this? What's the treatment to hyperventilation? Can't stick this on someone's face who's freaking out, right? It's common reassurance. Okay, so that's the word they use, common reassurance, right? We're frequently reassuring the patient. It's okay. I want you to take a breath in for 4 seconds, hold it for 4 seconds, breathe out for 4 seconds, right? Trying to slow someone's breathing down. And one of my favorite quotes that I teach is, in the history of telling a patient to calm down, it has never calmed them down, right? So think of like when you're pissed off and someone's like, dude, just calm down, right? That always calms me down when someone tells me to calm down. So don't tell patient, just calm down, God, it's okay, right? That doesn't work. You have to reassure them, hey, I'm going to be here with you. It's going to be okay. We're going to take good care of you. I want you to take a breath in, hold it for 4 seconds, breathe out for 4 seconds. We're going to do it together. Maybe a pat on the shoulder, right? Something like that to let them know you're here to help them, okay? You could even put on like a non-rebreather or something with oxygen, right? And like a little oxygen's not going to hurt them temporarily. So or a little nasal cannula or something. So it's common reassurance that fixes hyperventilation. Now, you can see hyperventilation in metabolic disorders too, right? Like you do see that, right? Diabetic ketoacidosis and stuff like that. But just be aware, the hyperventilation, right? So, take this to the bank, right? If you're taking notes. Hyperventilation equals respiratory alkalosis because we're breathing off too much CO2. Hypoventilation equals respiratory acidosis because we're not breathing off enough of that acidic CO2. All right, whoops. Causes of dyspnea. So shortness of breath or difficulty breathing is dyspnea. We've covered that, okay? Now, we can have a lot of reasons why this happens. And this scary little word, it's not a little word, but scary word right here, atelectasis, right? It's collapse of the alveoli. So imagine taking a bunch of grapes and just smashing those puppies, right? They're closed alveoli. They close up on themselves. It's usually from lack of surfactant and other reasons. But lack of surfactant is a really common cause of this. So the atelectasis, okay, is when the alveoli collapse on themselves. So I'll be dipped, right? If you shut down the atelectasis, you're going to have dyspnea, right? Because you can't have that gas exchange that we're working so hard for. Damaged alveoli, how does this happen? Infection, smoking, chemical exposure, right? Trauma even. So damaged alveoli. Obstructed air passages, right? So this is going to be a ventilation issue, right? So if we have a bunch of mucus or a battery, I'm saying battery because kids swallow batteries, it's weird, or a coin, stuck in an air passage, right? Shortness of breath, okay? Or blood clots. So if we get blood clots stuck in the pulmonic artery, that is it, remember the whole VQ thing, right? That's a Q issue. That's a perfusion issue, right? We're not delivering blood to the lungs. We don't have a problem getting air in and out when there's blood clots, but we have a problem getting blood in and out. So that's a perfusion issue. And then the pleural space filled with air or excess fluid. We're going to talk about these, but this could be like a hemothorax, a pneumothorax, a pleural effusion, a hemopneumothorax, something weird like that, all right? Empyema, something like that. A lot of different ways this happens. So patients with dyspnea will report a lot of things, right? First off, they're going to say, I'm short of breath. I can't breathe. Okay. And so this could present with air hunger. They're literally hungry for air. Okay. And chest tightness, right? They could say, I have chest pain. Right. They could have altered mental status. What's the single most perfusion organ in our body? The brain, right? Without 3 to 4 minutes of oxygen, you're dead. Right. So the brain, it's like, oh, I'm hungry. So we could see altered mental status. We could see a very common complaint you'll see with someone who's truly air hunger is aggression, irritability, right? So they'll become really aggressive, right? They'll start fighting you, not to be a jerk, but they panic, right? They become very agitated. Chest tightness. So dyspnea, again, it's a common disease, and it closely correlates to cardiopulmonary disease, right? To even cardiovascular disease or cardio disease, heart disease, because they're so tightly related to each other. So severe pain can cause a patient to experience rapid, shallow breathing without pulmonary dysfunction. You've seen this. You've hurt really bad, and you're like, oh, it hurts, right? That happens, okay? We've all been there. So I give you examples like this, guys. Like, you've been there. We've all been there where it hurts and we're huffing and puffing because it hurts, okay? So anytime on an exam, I say this all the time, don't just throw your hands in there like, oh God, I can't figure it out. Like, look at the question, right? Try to relate to yourself. What have I seen before? Has this happened to me? Does this happen to grandma or grandpa, whatever? All right. So they don't cover this a lot, but I'll cover it really quick. We can have infectious disease of the upper and lower airways. This one up here that they're drawing, this is called croup. We'll talk about this in pediatric stuff. Basically, it's a viral infection, the paramyxovirus, right, called croup, that basically causes inflammation of the trachea. So is the trachea upper airway or lower airway? It's lower airway. It's below the larynx. The larynx is there. So what happens is this will become inflamed. So it kind of, like the trachea, instead of being a tube like this, it looks like this. So as you can imagine, air going down through here makes a weird noise. That noise is called stridor. And so it sounds like this, right? That's stridor. It's inhalation, high-pitched breathing. And so what happens is a viral infection, and it has a very characteristic word they'll use on exams called a seal bark cough. And at the risk of sounding like a complete idiot, I'm going to let you know what this sounds like. It sounds like this. I can't even do it. I can't believe this is recorded. But anyways, it's like a seal, like clapping their hands and coughing. A kid will sound like that. You hear it one time, you'll know exactly what it sounds like. I'm doing my pediatric rotations right now, lots of croup. So you can hear this across the room. You're like, oh, it's a croupy kid. So that's croup, upper airway obstruction. Can't believe I just did that Silbert cough. That's what I'll do for y'all. Now, this other one, this is a bacterial infection. It's life-threatening. It's called epiglottitis. So our epiglottis is this little flap that sits over our larynx, our vocal cords. So when we swallow, it covers your vocal cords, so your deviled eggs and ham and Taco Bell doesn't go into your trachea. So it kind of like flaps like this over your vocal cords when you swallow. And when you're breathing, it's open. So what happens is you can get a bacterial infection of this. You should be vaccinated for this, but for whatever reason, people don't vaccinate their kids, so they get epiglottitis. And so it's a bacterial infection, and what happens is the epiglottitis or the epiglottis will become so inflamed, epiglottitis, that it can cover up the trachea. So how does this present? Good question. It presents with a patient who is drooling. You'll see this, a fever with drooling. Excuse me. And they'll usually be in the tripod position and leaning forward, the sniffing position. So they'll be leaning forward and they'll be just drooling because they can't swallow because because we use our epiglottis to swallow. So they won't even swallow their own spit because it hurts so bad. This is a life-threatening emergency. They have to go to the hospital immediately. Very, very, very big emergency when this happens, okay? So anyways, that's two just really quick examples of upper airway infection. Croup, right? Silbart cough, fever, viral infection, not deadly. Epiglottitis, very deadly. Bacterial infection, you should be vaccinated. Some people aren't. And it presents with a kid in a sniffing position fever who is drooling. They won't be able to swallow spit. Now, there's this thing called acute pulmonary edema. What's the word edema mean? Right? It means swelling. So when we see edema, we see this a lot, like pedal edema, right? Swelling of the legs, right? Swelling of the sacral. So let's break this down, right? Acute, very quickly, right? Pulmonary, lungs have edema, they have swelling. So this is accumulation of fluid in the lungs. And really this is intuitive, right? If you have fluid sitting in the lungs, do you think they're going to work the way they're designed? No, right? So there's several reasons why this happens, but it'll present with severe dyspnea, okay? And so severe shortness of breath. And fluid collects in the lungs and in the lung tissue. And you can see that here, right? So what happened, I'm going to jump into this because this is important. So this is the alveoli, but what happens is you end up with this fluid sitting in here, and you're like, well, what if fluid happened? It's not from someone sticking their head in the bathtub and sucking in water, right? That's drowning, and that's different. What happens in this case is almost always, not always, almost always, we get pulmonary edema from heart failure, okay? So what happens is, and again, not all patients with pulmonary edema have heart disease, okay? I'm laying the foundation, but virtually almost always it is because of heart disease. And or sometimes infection, but I'll come back to this. What happens in heart disease where we get pulmonary edema is the left side of the heart, right, starts failing, okay? It's usually fails from hypertension, okay? Like systemic hypertension. So what happens is the backflow, right, because blood comes from the lungs to the left side of the heart with oxygenated blood, or it's supposed to be oxygenated. And so what happens is the left side of the heart is failing, heart failure. It's not pumping efficiently. Fluid, blood, will back up into the lungs. So as you have this backup of fluid into the lungs, we have this weird thing called increased hydrostatic pressure, right? So we have this increased water pressure in the lungs. So you end up with like this dumping of water in the lungs because the lungs or the heart can't pump out the blood and the fluid from the lungs. So you end up with this sequelae, right, of pulmonary edema. And how does pulmonary edema present? How do we see this, okay? It presents with shortness of breath, dyspnea. We've talked about that. It also presents with this weird thing that you're going to see a lot. This is not me being fancy or your book being fancy. Orthopnea, okay? Ortho, like an ortho doctor, means bone, right? Or like structure. And so orthopnea means that they get short of breath laying flat, okay? So you've probably seen grandma or someone like that sleeps with like a bunch of pillows, or they sleep in the recliner because their heart's failed. And so what happens is if they lay flat, they feel short of breath. So they cannot lay flat. So you can almost gauge someone's heart failure by asking them, do you sleep in a recliner? Yes or no? Or how many pillows do you sleep with, right? If they sleep with like 8 pillows because they're pretty much sitting up, it's because they have orthopnea. So a common complaint you'll see in a vignette, they'll say, patient gets severely short of breath when laying flat, right? It is better when they're sitting up. And this is the reason we sit patients up that are short of breath on the ambulance. Always. Don't lay patients flat that are short of breath. Ever. Just let them sit up. Okay, so let patients sit up that are short of breath. And there's a lot of physiology to this. It's way above our head for now, but just take Hunter's word for it. The lungs work better when you sit up. Okay, perfusion and ventilation. Think about laying flat, especially if you're fat, right? There's a lot of your lungs are pushing down like this and up if you're laying flat. Okay, it has to like push up on all your chest fatness. But if you're sitting up, you don't have to do that, right? You're just moving the diaphragm at that point. So we breathe better sitting up. Take Hunter's word on that. We also perfuse. The lungs perfuse, right? This whole oxygen gas exchange, take my word, it's very complicated. I'll explain this to you on the side if you want. It works better when we sit up. So orthopnea is shortness of breath when laying flat or not sitting up. Fatigue. Of course you're going to be fatigued, right? You're not perfusing well. You're having to work really hard to breathe. Reduced exercise capacity. And this isn't necessarily going to the gym and doing the Stairmaster. This is going to the bathroom and back, making food, just regular getting up and moving out of bed. For older people, that is their exercise, okay? So don't always think, when you see exercise, don't think like, oh, they're going to like row 1,000 meters on the rower. That's not what I'm talking about. I'm talking reduced exercise capacity. They get short of breath in the store, or they get short of breath walking to the bathroom or wherever, okay? Pulmonary crackles. Holy crap, okay? Pulmonary crackles, right? Students get real freaked out on this word. What do crackles sound like, okay? If I were to take a Sonic cup, okay? I meant to get one, I forgot. And take a straw and breathe in there, right? It's that sound of water with bubbles in it, right? We all know what water with bubbles sounds like. That's crackles. Because think about it. In your lungs, it's crackling, right? Because you're breathing through water. So when you put your stethoscope on someone's crackles, okay, it's going to sound, let me grab my stethoscope. It's going to sound like they're breathing underwater because they are, right? So where are you going to typically hear this if a patient's sitting up? Because gravity is on your side. It's in the bases. You typically hear crackle in the bases if they're sitting up because fluid kind of shifts downward, down to the bases. So you're going to hear crackles in the bases when you listen. And where students get confused, because you'll still see this, is crackles, also known as rails. Crackles, also known as rails. Crackles used to be known as rails. So these two words that they're using on this confuses students and it freaks them out. So crackles means rails. What do crackles sound like? It sounds like crackly water, like you're breathing through a water. And so I'm going to link in this video and on Canvas for sure some videos of crackles, rails, stridor, rhonchi, and what those sound like, because those are spot diagnosis that you need to pick up and be like, booyah, that's crackles, that's rails. There's pulmonary edema. Is there pulmonary edema because infection? Is there pulmonary edema because their heart's failing, right? So that's where we got to go next to figure out what is the cause of this, okay? Going back over here. Now, acute pulmonary edema, chronic obstructive pulmonary disease. I've been talking about this, okay? And I wish I kind of would have explained this earlier, but this will make sense now. Break down the word, right? Chronic, long-term, obstructive, what? I'm going to talk about that. Pulmonary lung disease. So long-term lung disease that's obstructive, okay? So what happens is the lungs, this happens throughout life. So all of us, by the time we get 80, 90, will have some degree of COPD. Just from environmental toxins, right? Car exhaust, pollutants, just life, right? But cigarettes are extremely acceleratory for this. And very, very commonly this will happen. So when someone smokes cigarettes, which is toxic, okay, not my opinion, toxic, it damages the lung tissue. And I'll explain to you the pathophysiology. You don't need to necessarily repeat this back to me, but it'll make sense. What happens is when you breathe in cigarettes, it's toxic. And so that toxic smoke goes down into the lungs. Well, the lungs are like, yo, that's toxic. So what happens is the body will respond with inflammatory response. And it'll be like, oh, there's toxic stuff in our lungs. Let's go ahead and get rid of this. So what happens is the body will react. And so these little neutrophil guys, right, little Pac-Man guys, white blood cells, will go in there and they'll start releasing this stuff called elastase. And elastase breaks down elastin. And what do our lungs need to have good elastic recoil? Elastin. So elastase breaks down elastin, and it's released from neutrophils, and neutrophils are triggered by the smoke, by pollutants. And so as this happens over years, right, really probably a decade or more of smoking, you'll end up with getting COPD, chronic obstructive pulmonary disease. And so this obstruction will occur in the bronchioles. It also damages the alveoli. And so we can get several COPD is this big umbrella, right? There's my umbrella. And under this, we get a little bit of asthma. We get a little bit of bronchitis. We get some emphysema. right? Those are really the three that fit underneath this umbrella. And they happen actually in this order. 1, 2, 3, right? And so I'll talk about how these present. But basically, you can end up with asthma, right? So they'll end up with wheezing, okay? And this is just the environmental response of like, oh shoot, there's toxins in our lungs. Let's react, release histamine, and we'll clamp down the bronchioles, and we'll try to keep these toxins out. Blah 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 blah. Okay, so that happens. And eventually, as this happens so much, your body will be like, there's so much toxins. Remember, how do we fight pollutants and toxins in the lungs? One of the ways we do that is with mucus glands. So we produce a lot of mucus because we're like, well, we'll just trap up this toxin and we'll just hold on to it in mucus and hopefully cough it out or swallow it. And so what happens is these mucus glands will become hypertrophic, right? Or hyperplasic, really. They increase, okay? Excuse me. And so what happens is the mucus glands increase, so you end up with a lot of mucus. So here's how this will present. We have these things called, I'll come back to this. I'm getting ahead of myself, okay? I'm going to come back to that. So we can end up with pneumonia when the airway passages are persistently obstructed, right? And so this repeated exposure of toxin, again, creates this inflammatory response, and your body will start fighting a big war inside your lungs. And this big war causes damage, okay? And so really, cigarette smoke in of itself, bad, but your response to the cigarette smoke is what causes COPD. And so you get these repeated pulmonary infections and these repeated exposure, bronchitis, bronchiectasis, stuff like that. And that causes damages to the lungs. And one thing I need you to know, and you've probably seen someone who smokes a long time, is chronic bronchitis is what they call the blue bloaters, okay? And a blue bloater, is they'll be like kind of bloated. They'll have this big belly. They're usually fat or obese, excuse me. They're obese, overweight. By the way, when I throw the fat word around, I'm not like fat shaming. I'm just trying to be efficient. But anyways, they'll be overweight, and they'll be called blue bloaters because they're bloated, and they have this bluish tinge to them, right? And you've probably seen them, and they also tend to be mouth breathers, and they just cough up buckets of mucus, right? They're always just coughing up the next loogie. And so what happens is this is bronchitis. It's chronic bronchitis, and this chronic inflammation damages the lungs. Well, eventually, you'll end up with something called emphysema. And emphysema is the last stage of this, the most severe. And emphysema, and it doesn't have to go in this progression, but this is the typical progression, right? Asthma, bronchitis, emphysema. What happens with emphysema is, remember me explaining to you that we have these grape-like clusters, right, within our lungs, called the alveoli. Well, when they get damaged, they stop looking like grapes, and they start looking like a shopping bag. And so really imagine this, right? Instead of having these little like balloons, right, all within the lungs, right, that have all this elastic recoil, and they're always like, they're real squishy and like got elastic recoil where they'll expand and contract the way they're designed. What happens is with emphysema, instead of like these grapes, like clusters, it looks like this, right? It's just a shopping bag. So think about this, right? If I were to blow up a balloon, like a rubber balloon, like a clown, right, and let go, it has elastic recoil and it shoots air out, okay? But if I were to blow up a shopping bag and let go of the shopping bag, right, like a Walmart bag, does the air really force itself out really efficiently? It doesn't. And that's what's happening in emphysema. In emphysema, instead of having a bunch of little clown balloons in your lungs, right, you end up with a bunch of Walmart sacks. And these Walmart sacks don't have a lot of elastic recoil. So we end up with obstructive pathology, okay? And just like bronchitis, right, because of the mucus buildup, you can't get air out. The same thing happens in emphysema. You can't get air out because you're lacking elastic recoil from the alveoli to force that air out. So you end up with obstructive lung pathology. And so just imagine that with emphysema, right? Instead of a balloon, right, and letting go of the balloon and air forcing itself out because of the elasticity of the balloon, you have a Walmart sack. Now, Walmart sacks don't have any elasticity. So you end up with this air trapping, okay? And so that is the two main parts of COPD. Well, how does this present? Remember me telling you about the blue bloaters, right? They're bloated, they're kind of fat, and they have this bluish tinge. They're coughing up mucus. That's chronic bronchitis. It's a form of COPD. It's from smoking for probably a decade or more. This is what they call a pink puffer, okay? Pink puffer, okay? Why are they called pink puffers? It's because of the way they look. They tend to have polycythemia at this point, okay? Because of the lack of oxygen, because their alveoli have been destroyed, and they tend to be really thin. Why are they thin? This is crazy to me. That they lose weight because of how, I'm not making this up. They lose weight because of how many calories they burn just to breathe throughout the day. Their work of breathing is so laborious. They have to work so hard just to breathe. They lose weight because of it. So they end up really thin. Okay? So you've seen the nasty little smoker mechanic guy, right? That looks like this. Because of how hard they have to breathe, they burn more calories than they consume, so they lose weight. What a diet, right? So they end up losing weight. So they end up really thin, and they call them pink puffers because of the polycythemia, and they puff, okay? And here's how this looks. First off, I want to point out how this guy is sitting. He is in the tripod position, right? Hand on his legs, leaning forward, trying to breathe, okay? He's also in the sniffing position. What's the sniffing position? I had a candle in here. But if I were to sniff a candle, right, you lean forward, right, to open up your passages, okay? We do that naturally. So he is literally leaning forward, fighting for air, right? And he is in the sniffing position. And so this is COPD. This is emphysema. This is a chronic lung disease, chronic obstructive pulmonary disease, COPD. And so it is, and then I want to point out this, right? They exhale through pursed lips. So again, if I told you to run to the stop sign and come back, and you're like, what do you do when you're all tired? You do this, right? You have too much CO2. So you end up like grabbing your legs and huffing and puffing. And sometimes you go like this, right? You'll purse your lips to create a positive pressure, right? So there's this thing called PEEP, right? Positive expiratory end pressure. And so you will physiologically purse your lips to increase the pressure within your lungs, okay? So that's called PEEP. It's complicated. We'll talk about it later. But basically, you'll breathe through pursed lips when you end up short of breath. So the reason they call them pink puffers, polycythemia puffers, because they breathe through their lips like that. They're right? They breathe like that all the time. Like how exhausting that would be. That's why they lose weight. They also have chest tightness and constant fatigue. They are fatigued because they're having to work that hard to breathe. Lastly, they have a barrel chest, okay? Barrel like a wine barrel, like a whiskey barrel. The barrel chest is because their lungs are hyperinflated. Their lungs become the shopping bags are holding so much air in their lungs instead of balloons or shopping bags. Their lungs become hyperinflated. So you'll notice this guy's chest is remarkably round. Okay, it doesn't look right because his lungs are hyperinflated. And if you were to shoot an X-ray of this guy's lungs, it's a very characteristic sign. The diaphragm's pushed down because the lungs are so inflated. Okay, what heart condition can you get from chronic obstructive pulmonary disease? Cor pulmonale. Is that left-sided heart failure or right-sided heart failure? Right-sided heart failure. Now with that, heart failure doesn't happen in exclusion for long, right? One side of the heart fails and the other side will fail pretty quickly afterwards. But just let that be known, okay? It's cor pulmonale. Now, here's what this looks like. And I explained this to you, right? Normal lung, right? These are clown balloons, little balloons that you see at a birthday party, right? Very elastic. This is, chronic bronchitis. It's an inflamed lung, right? So imagine trying to get air out through there. It's really hard, okay? So you end up with chronic bronchitis. What's the lung sound we get with chronic bronchitis, right? We'll get wheezing because it's obstructive pathology. What's wheezing? It's a high-pitched noise on exhalation in the lower airways. But we'll also get rhonchi. What's rhonchi, right? So remember me saying if I were to take like a sonic cup, like an ocean water, one of my favorites, and breathe and like blow in it, it sounds like water. Well, what if I took a hot fudge shake? Love those. And breathed in that, right? It has to be pretty liquidy. It sounds like plop, plop, plop. Like it sounds like ploppy, right? So imagine breathing through mucus or pus, right? It has a different sound. It sounds more mucusy. That's rhonchi, okay? So rhonchi, hot fudge shake, mucus, right? It's very plop, 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 ploppy, right? Compared to rails, It's going to be very watery. Wheezing is high-pitched expiratory, right? We've all heard wheezing. And again, I'll have some in the comments or in the info section of this video. I'm going to have like a list of lung sounds for you to listen to, and it'll be on Canvas. So, oh, and then lastly, this one right here, right? This is emphysema. So emphysema is when the alveoli become destroyed, and they instead of balloons, they become shopping carts or shopping bags. Okay, and also you end up with chronic obstruction. Okay, an infection. So general pathology rule I've told you before. Anytime we have obstruction, like here or here, right, or in the ureters or wherever, in a skin pore, right, that's acne. You'll end up with infection. Okay, that's a common pathology you need to know. So I'll say that again. Anytime there's obstruction in a tube or a duct or a lumen, behind that you're going to end up with infection, almost always. Now, asthma. We see this a lot. This happens a lot. And so it's acute spasm of the bronchioles. Where are we at on slides? We're going to finish this and we'll take a break. So acute spasm of the bronchioles. So remember, the bronchioles have smooth muscle, not skeletal muscle, smooth muscle. Do we have control over smooth muscles with our brain? Can I say, hey, smooth muscle buddy, contract? You don't, right? I can't consciously think that. They're underneath autonomic control. So what happens is you get acute spasm of the bronchioles, which are the small airways, right? And the smooth muscle will clamp down. And as you decrease the lumen of a tube, right, you have less stuff going through it, in this case, air. So you also will end up with an asthma, which we get the whole bronchospasm thing. Paramedic and EMT students get that part, but we tend to forget about this whole mucus production stuff. Okay, so basically, with this, you'll end up with increased mucus production. So they'll end up coughing, and they could have a little bit of like bronchial. Maybe, I mean, it's kind of extreme sounds. I wouldn't expect those always, but it can happen. Okay, so it's a combination of smooth muscle spasm, mucus production, and edema. Why does this happen? Okay, so it results from allergic reaction. Okay, so what happens is, let's just say you're allergic to pollen, okay, or dander. Let's just say pollen. Okay, I don't care, pick one. Pollen, dander, cats, whatever. And what happens is when you breathe this in, you know, we have these little white blood cells sitting in the lungs, and they're like, oh no, pollen, bad. We need to react. So it'll dump off from the eosinophils, the mast cells, right? These white blood cells, these specific ones, and it releases histamine. And so when it releases histamine, histamine makes smooth muscles contract, right? It happens a lot in our body, but we see this pathology in asthma because histamine is released. So it causes smooth muscles to contract. It also causes vasodilation, which will lead to edema, and it also causes, mucus production because of the histamine and edema and inflammatory response. So we can get this from, and how we see this is shortness of breath and wheezing, okay? And coughing, you'll see coughing. And dyspnea, okay? So it can happen from an allergic reaction. It's probably the most common way this happens.